So, for those of you who don't know me, my name is Kashette Rahman, and I am a reference librarian and the head of adult programming at the Irvington Public Library. With us today is Colin Sandler, who's going to be presenting Navigating the Maze of Long-Term Care. Colin is a licensed clinical social worker with Medicaid Solutions of Cortland Manor, and is going to talk to us today about how to help manage the cost of long-term care in your home or in a nursing home. I'm going to shut off my audio and video and keep an eye on technical matters, but I'll pop back in at the end or if there's anything else that needs addressing. With that, I'm going to hand things off to Colin.
Thank you so much, and thank you for allowing me to speak today. It's wonderful to be able to present this information, which I think is super important for people. So I'm going to share a PowerPoint, mostly just to give, because you don't need to look at my face the whole time, but also because I think words kind of help supplement the information. So hopefully you are seeing my screen, and if you're not, please let me know. So
it's coming through okay.
Excellent. Thanks for that. I appreciate it. So basically, I'm going to kind of skip over a couple of these slides, but bottom line is the cost of care is enormous. And people start to look at, what do I need to do? How do I keep my loved ones safe? What type of care is out there? What's the cost? And as you start to enter this world, the questions really start to pile up. And most people don't know where to turn. So my job and my role is to help educate people to determine, what the services are, how to access them. Most people do not have long-term care insurance, and those who do, not everyone has the type of long-term care insurance that fully covers everything or that covers indefinitely, and people are living longer than their policies last, and cost of care is often more than the policies provide. So even people who have that lovely benefit may not have enough to cover them. And that's when people turn to Medicaid. So basically, my goal today is to educate you guys about community Medicaid and nursing home Medicaid, both of which can provide coverage for services. And not everybody thinks they're eligible for Medicaid, and they may not be correct, and they may not understand what the rules are. So that's my goal today. So best place to start is to sort of educate you about the two different kinds of Medicaid eligibility that are out there. So the first is community Medicaid. Community Medicaid covers services in your home. That could mean in your own home, your house, your apartment. It could mean the home of a family member, your child, your grandchild. It doesn't matter physically where you are, as long as you are not in an institution. Community Medicaid also can cover services in an assisted living facility. And I will explain that in a private assisted living facility that doesn't accept Medicaid, you can go in, pay the rent if you can afford it, and utilize Medicaid benefits to offset some of your care within the facility, as long as they allowed outside vendors, meaning outside agencies, to come in. Many do, some do not. But if the facility you go into, if you can afford the $5 or $6 grand a month as the base rent to live there, but can't afford the supplemental care that you need there, you can use Medicaid, and it would be community-based Medicaid. There's also Medicaid assisted living facilities. There's only one in Westchester that you can go in on Medicaid to start with, and that's in Yonkers. There is another one opening in Mohegan Lake, hopefully shortly, and there are a handful in the Bronx and as you go north. I think we'll be seeing more and more of those, but that is somewhat limited at this point in time, that availability. Medicaid in the community pays for home health aides. It pays for somebody to come and help you with your personal care. They also pay for incontinence supplies and medical transportation, and there are some other side benefits as well. You do not have to give up your Medicare to qualify for community Medicaid. So you keep your Medicare benefits. If you have a supplemental policy and you want to keep that, you can keep that as well. And Medicaid will always be the payer at the bottom of the pile. So if you have Medicare and an AARP supplement, Medicaid will be your third payer, but it's going to pick up the things that your regular insurance doesn't cover, which is long-term home health aides, incontinence supplies, medical transportation, etc. Currently, Community Medicaid has no look back period for transferring assets, and I'm going to explain what that means in a moment. Nursing home Medicaid is different. Nursing home Medicaid covers care in a nursing home and is usually meant for permanent care, meaning you're going to a nursing home and your plan is to stay there indefinitely. You're not planning on returning home. It can, however, also cover an extended stay in a nursing home. So you're in a nursing home for short-term rehab, you had a knee replacement or a fractured hip, and your insurance cuts your coverage after 2 months or 3 months, but you're not fully rehabilitated and you're not ready to come home. If you do not have the resources to pay, you can apply for Medicaid so you can stay longer, even though your intention is to, in fact, return to your home. Community nursing home Medicaid has a 5-year look back. So what does that look back mean? The look back means that Medicaid's going to want to see a very detailed review of all the financial accounts associated with the person applying or their spouse. They're looking for details. In Westchester County, they actually only ask for information on transactions that are $3,000 and over, but everywhere else in the state, it's $2,000 and over. I have no idea why, but that's how it rolls. So what they're looking at are deposits and withdrawals. It's not just withdrawals. And they want to know where money came from that was deposited and where money went to that was withdrawn. And if any money was given away to a family member as a gift, even if it was just, for instance, helping a grandchild with college education, but you gave the money to your daughter to pay the college, Medicaid's going to see that as a gift. If you gave a wedding present or a graduation present, we can usually get out from under that if it's a reasonable amount of money, but they can really say anything is an uncompensated transfer, meaning it's a gift for which you gave them something and they gave you nothing in return, and they will penalize you for those gifts. And the penalty is that they refuse to pay for your care for a period of time based on the amount of money that was given away. So there are changes coming to community Medicaid. Nursing home Medicaid is unchanged. It's the 5-year look back. It's been that way since 2006. In community Medicaid, as of today, you can still transfer assets. So you can give away, you could have $1 million today, give it away tomorrow and qualify for Medicaid starting in May. However, that's changing. So as long as you transfer your assets before November 30th of 2021 and file a community Medicaid application as of December 31st, 2021, you can still qualify under the no penalty for transfers rule. That is still a thing. It was supposed to change in October, but they've been postponing it due to the pandemic. So after January 1st of, and it should be 2022, so forgive my typo, it is January 21st, 2022, Medicaid will be looking back to October of 2020 for transfers of assets. So starting in January, there's going to be a 14-month look back for community Medicaid for any applications received after January 1st. And each month after that, they're going to add a month to the look back period. So in February, it's going to be 15 months, still back to October of 2020. So that's the hard line in the sand. They're not going back past October of 2020, but they will be going out to a 30-month look back, which will be fully implemented by April of 2023. Anybody that transferred assets, created a trust, gave away money, did anything like that prior to October of 2020 will not be penalized if they're applying for community Medicaid. They won't ask you for records prior to October, no matter when you apply, ever, for community Medicaid. Nursing home Medicaid, different, but community Medicaid, that's the hard line in the sand. So for those people that heard about the changes and did their planning, but didn't apply yet, they should be in good shape, even if they apply 2 years from now. For those people who didn't do their planning and are planning right now, you will get caught in the look back period if you need services within a 2.5-year period. So how do we qualify for Medicaid? So this is based on assets, this screen. Medicaid looks at assets and income, and they treat them differently. So I separate them into 2 different categories. So assets for a single person, and that could mean you are one half of a married couple and your spouse is refusing to contribute, or you could be single because you're divorced or widowed or never married. Those would be the other options for being single. That person can have no more than $15,900 in countable assets. For a married couple where both people are applying, or if the couple genuinely has less than $23,000, then they could qualify. I don't have a lot of couples that apply for Medicaid at the same time for the same services, but it does happen. And that would be the limit, $23,400. So I mentioned countable assets. That's a very important word. They look at countable assets. So what's countable? Any funds that you or your spouse, or if you're joint account holder with your children on anything, any asset that the applicant's name is on has to be disclosed. Checking, savings, CDs, investments, stocks and bonds, annuities from which you're drawing no income. I always pause at the 529 accounts. 529 accounts are savings accounts that people open for their children, grandchildren to save for college. People do the 529 accounts because there's a tax benefit. The person who opened the account owns the account, not the person you're saving for. So if you're 75 years old and you are saving for your 10-year-old grandchild in a 529 account that you own, you are risking the money in that account should you need long-term care. So I highly recommend that grandparents really refrain from owning those 529 accounts and contribute towards an account that their child may own for their grandchild. And if you do have one, you might want to think about transferring that over to the adult parent so that they can have the money protected. Otherwise, you will be forced to cash it out and use it for care, and that would be tragic, I think. Properties other than your primary residence are countable. However, if you're applying for nursing home care and you are the only one living in your primary residence, it also would be countable. I'll expand a little bit on that in a moment. So just to give you an idea, if I own my house and I have an empty lot that is adjacent to my property, I've always considered it part of my property, but I have a separate deed for it. That property is a countable asset. Medicaid will count it as available, and the value of it will be a resource to me. So I may have to actually sell that lot to qualify if I need Medicaid benefits. Obviously, if I own properties other than my primary residence, I have a house in Florida, I have a condo on the beach on Long Island, those are countable assets if I own them. Cash value of your life insurance is also a countable asset. So a lot of people don't understand life insurance, but whole life insurance has cash value over time. So as you hold the policy longer and longer, it accrues value. And at any point, you can tell the insurance company, I don't want this policy anymore. I don't want to stop paying. I want to take the cash out of the policy and get rid of it. That cash value is an asset, dollar for dollar in Medicaid's eyes. So I might have a $100,000 life insurance policy and have $20,000 in cash value. As long as I own that policy, if I'm the applicant, I will never qualify for Medicaid. It is the person who owns the policy that owns the cash value. So if I bought, and I see this frequently, if I bought one of those Gerber life insurance policies for my child and I bought it in 1960 and I still own it for my child, that is my policy. The cash value belongs to me. It's not who gets paid at death. It's not who's insured. It's the owner of the policy, just so you understand, because that's a big confusion for a lot of people. What is not a countable asset? Well, first of all, retirement accounts, IRAs, 401ks, 403bs, whatever you want to call them, any kind of retirement account from which you're required to take a distribution at any point in time, even a Roth IRA from which there's no required distribution, it's still an IRA. If you take a distribution from your retirement account consistent with the IRS's formula for taking distributions, the principal will be protected. The income will be counted in the discussion on income in a moment, but the principal would be protected. Westchester County does use the same life expectancy table as the IRS uses. So if the IRS says you're 73 years old, you need to take X per year out of your IRA, that's the formula that we would be using. Most of the rest of the state, except for the boroughs of Manhattan, the city. Westchester and Putnam, those are the only places that use the IRS calculations. The rest of the state use a different life expectancy table, and it does require that you take a higher distribution. So it will be the income that you derive from these that will be counted, not the principal. And the nice thing about that is most IRAs or annuities or any kind of retirement account has a direct beneficiary. So that will pass to your heirs upon your death, whatever's left, but you will continue taking the income as you're required to do. You can put a Roth IRA into payout, which is not required to have a distribution, in order to protect the principal. If you don't do it, the principal becomes countable. Assets owned solely by your spouse, even if you transfer them to your spouse to qualify under spousal refusal, are technically not countable. And I say technically because you can do something called spousal refusal, where you say, I'm not paying for my spouse. I own these assets solely. I'm not giving them up for my spouse's care. And Medicaid has to approve that sick spouse's needs. However, the county that you live in can and most likely will come after you to try to get you to pay something. Depending on the circumstances, it is often still a valuable and viable strategy, but it really depends on how many assets the well spouse has, how much income the well spouse has, and how much care the ill spouse is going to receive, whether it makes sense to go with that strategy. So that's something that has to be sort of determined individually. Another important loophole is assets transferred to an adult disabled child are exempt. Always, across the board, even if you're going into a nursing home. So if you have an adult disabled son, maybe he hurt his back on the job, he's married, he's got Social Security, he's got a pension, he's got money, he owns a house, but he's out on Social Security disability. You can give all of your assets to that child on the day you walk into a nursing home, and they will be fully protected despite the 5-year look back. But you can't give it to your non-disabled child. That works great for that situation. But if you have an adult disabled child who's been disabled their whole lives, they may also be receiving government assistance. So you may have to be very careful about what you do and what you transfer. And sometimes people will do a supplemental needs trust or for that adult disabled child that's been disabled all along. Again, that gets into sort of the weeds of planning, but broad strokes is you should understand that that is a loophole. Your primary residence is exempt from Medicaid as long as your spouse, an adult child caregiver who's been living in the house for 2 or more years with you as your caregiver, or a sibling with an interest in the house is living in the house. So if I go to a nursing home and my husband stays in our house is exempt. If I go to a nursing home and my daughter's been living with me and caring for me in that home for more than 2 years, my house is exempt. However, if I live in my house alone and I'm going into a nursing home, it has to be sold. If I'm living in my house alone and I'm going on Medicaid for home care, my house is exempt. But if I've done no other planning for the ownership of the property, Medicaid will come after the house when I die through estate recovery. So it's not a slam dunk. The house is just not exempt because you're staying in it. Again, more planning needs to be done, but you certainly can qualify if you own your house and you're staying in it and you want to apply for Medicaid for home care. So income for nursing home eligibility is different from income for home care. So if you're single, there's no spouse at all, you must contribute 100% of your income to the nursing home on a monthly basis. And that is your gross income before any taxes are withheld. So you have to stop all withholding if you have taxes withheld. And then you are allotted, excuse me, a $50 per month stipend for personal needs. That $50 has been the same for 30 years. It's hard for me to imagine that they've never increased it, but it has not been increased. I started working in a nursing home in 1988 and it was $50 then, it's still $50 now. If there is a spouse, you have 2 possible scenarios. One is if the married couple has a gross monthly income of under $3,200, $3,259.50 to be exact, the institutionalized spouse would give only the income to the nursing home that is over the $3,200. So if I need a nursing home and my income is $1,500 per month and my husband's income is $5,200 a month, we are below that threshold. the nursing home would let my husband keep 100% of our income. If I need a nursing home and my income is $1,000 a month and my husband's income is $3,000 a month and he goes into a nursing home, I'll be able to keep $2,000 of his income to bring me up to the $3,260, and the rest of his income goes to the nursing home. So that scenario is better suited for low income people. It works really poorly if the well spouse is the lower wage earner. You might lose a lot of income to the nursing home because you will not be allowed to keep more than $3,200. If the well spouse has more than $3,200 worth of income, the well spouse can keep all of their income under spousal refusal, but all of the income of the spouse in the nursing home will go to the nursing home. So if I have $3,200 a month in income and my husband has $3,200 a month in income, I can keep my income, but 100% of his income is going to the nursing home. So again, that will work better when the well spouse has much more income than the ill spouse. And unfortunately, there's not a lot of wiggle room here. I'm told you can go to a fair hearing and argue, but I'm told people don't usually win those arguments. I had a lady who had about $6,500 a month in income coming in between her and her husband, of which under $1,000 was hers. So when he went into the nursing home, she lost about $3,000 a month of income and can't afford to live in her home anymore. And there was no wiggle room. She had no choice. She had to figure out another living situation. So it can be really unfortunate in that scenario. So income eligibility for home care works differently. So if there is no spouse or you're doing a spousal refusal, they look at you as single in that instance for income. You can keep $904 a month of your monthly income plus any out-of-pocket health insurance premiums. Any money above that is called a spend down or excess income, and you can either pay that excess income to Medicaid or you can utilize something called a pooled income trust to shelter that income, which is what most people do. Typically, if the spend down is less than $200, people are on the fence as to whether or not they'll do a pooled trust, but usually anything over $200 a month, people will use a pooled trust. And I've seen people put as much as $6,000 or $7,000 a month into the pooled trust because they're over by that much. If there is a spouse, again, there's two scenarios. One is back to that spousal impoverishment budget. Same thing that I mentioned for nursing home. If you're both combined under $3,200, the well spouse can keep 100% of the income, but you have to be on something called managed long-term care, which I'll tell you about in a little bit, which is not always the case. Otherwise, we're back to spousal refusal, where the well spouse keeps their income in its entirety, and the ill spouse is under the single option, which is we can still protect their excess income through a pooled trust. The well spouse gets to keep theirs, and that is usually the scenario that I use most often with married couples in the community. This is just a little explanation of what that pooled income trust is. You can only use a pooled income trust for community-based Medicaid. It is not an option for nursing home Medicaid. It shelters the excess income that Medicaid wants you to take away. They pay your expenses at your request directly to the third party. You say, here's my Con Edison bill, it's $50, please pay $50. The pooled trust cuts a check to Con Ed for $50. So they are paying the third party directly. The bill that you ask to be paid must have the name of the person who belongs in the pooled trust. So if I'm asking them to pay the Con Ed bill and I'm on Medicaid and I'm in the pooled trust, that Con Ed bill has to be in my name. It can't be in my husband's name. It can't be in my daughter's name. Must be in my name. It can be in my name and somebody else's name, but my name must show on the statement. It's a lot like an online checking account. You tell them what to pay, they cut the check. It's also like a checking account in that you can ask them to pay up to what's in the account, but you can't ask them to pay more than what's in the account. They will tell you there's not enough to cover that charge. You can make a partial payment or you pay a different bill. If you don't use all the money in a given month, that money is gathered in that account and accrues in that account, just like it would in a checking account. The downside of letting money accrue significantly in a pooled trust is when the person in the trust dies, the trust gets to keep the money that's accrued. So the goal usually is to spend as much of that money per month as you can. This is just a little chart to show you how Medicaid looks at income. So in this particular scenario, this lady's got $1648.50 in gross income. That's before any deductions from Social Security. She's got a $500 gross pension and $550 per month in her IRA distributions. So that gives her $2698.50 in monthly income. Then they take away her Medicare premium, which is already pre-withheld from her Social Security. So they edit it back and then they take it away. And then she's paying $300 a month for AARP, and she's paying $40 a month for her Part D prescription plan, and they're allowing her the 904. So all those red items are deducted from that total on total monthly income. That leaves a spend down amount of $1,306 per month. So that's what's going to be her spend down. So each month, the pooled trust is going to reach into her checking account with her permission and pull out the $1,306. In this particular case, with this trust scenario I'm using, they have a sliding scale. The trust will take a fee. All trusts have monthly fees. They range on a sliding scale from about 7 to 8% to up to 10% for your deposit. So they take the fee out of the deposit that you made, leaving this person with $1,230 in her pooled trust and leaving her with $1,244 in her checking account each month. The pooled trust could pay her rent, her telephone, her electric, whatever is appropriate, and whatever that $1,230 doesn't cover, she can use the money in her checking account for it, but she also has to use the money in her checking to pay her health insurance premiums. The trust will not pay health insurance premiums, life insurance premiums. They will not pay for alcohol, cigarettes, illegal activities, or gifts. Those are off the table, but everything else is somewhat flexible. So how do you transfer assets to qualify for Medicaid at home? If you're transferring a smaller sum of money, mom has $20,000 over the limit, you could consider moving it to a new account in a trusted family member's name. But if you have significant assets, property, investments, brokerage accounts, stocks and bonds, life insurance, most people consider an irrevocable trust, which you do need an elder attorney lawyer for. And an irrevocable trust is a great tool because it shelters the assets, but it means it's not in the name of your children. So if your child gets divorced or has financial trouble or something happens in their personal life, that money doesn't technically belong to that child until you die. So it's a way to shelter it without actually having it be on your child's tax return or anything else like that. But whichever way you decide to transfer money, there's 2 points we have to keep in mind. If you transfer assets before November 30th of 2021 and apply for Medicaid before December 31st, you will still qualify under the old rules and there will be no penalty for transfers. However, if you create a trust today or next month or 2 months from now, but don't apply for Medicaid before January 1st of 2022, you will have to wait for 30 months to qualify for community Medicaid. So obviously, we're not going to apply for somebody who doesn't need anything right now, but if things are looking like you're going to need something, I'm encouraging people to consider getting an application in earlier rather than later, because you're going to get stuck in that 2.5-year period where you're going to have to spend your money. If you are married, you can transfer your assets to your spouse without penalty. So this deadline really doesn't apply to spouse transfers. It really applies to transfers outside the marriage. A trust is outside the marriage. Your children are outside the marriage. So what we do really depends on what you need and what your timing is. And obviously we're going to run into people as we get into next year that didn't know this information and didn't do their planning. And they're going to be in a very different position as far as being able to qualify than it has been forever. So I've been doing this for 25 plus years, and community Medicaid always allowed you to transfer, and that is going to change. So there is something called a gift note, which is going to be a tool that we're going to use to protect assets for community-based Medicaid once this look-back period is fully installed. And basically, without reading this whole thing verbatim, the gift note strategy, which has been used in nursing home Medicaid for some time, basically allows you to transfer about 50% of your assets and then apply for Medicaid, let Medicaid penalize you for giving away that money. And then you pay for your care through the penalty period using the money, using the other half of the money, which is usually used as a loan. It's very complicated. We don't really know how it's going to shake out for home care Medicaid exactly. But when I talk about the nursing home piece, we do know how it shakes out there. But the bottom line is it allows you to protect assets. We do think that there'll be some other strategies that come along as we really start to be into this period where the look back is applied. But I'm not sure that everybody really has their arms wrapped around what's going to happen. An annuity is a way to protect assets. So if you have somebody who's got like $50,000 or $100,000, it is significant, but it's not a significant amount of money in the Medicaid world. You could even just buy invest in an annuity, take a monthly income consistent with the IRA formula, and make that money protected. Your children can inherit it when you die, and you have an income stream, which you can shelter that income under the pooled trust. That was a lot I just said in that sentence, but that's the kind of planning that you get when you work with a specialist or an elder law attorney to get things rolling. So again, I apologize because I guess I missed two changes here. This screen pertains to the gift note strategy that I just discussed. And that will probably be the way that we're going to protect assets. There is some talk about, and I'm going to come back to the home care services in a moment. There is some talk that there was possibly going to be some exclusion for transferring property under the community Medicaid law. That's coming, the changes, but we don't know about that. There's also some talk that a certain type of home care program called the Nursing Home Transition and Diversion Program will not fall into the community Medicaid look back issue. So you'll still be able to transfer assets. So again, these are some things we're going to all have to check back with as we get into the changes when we get closer to January, or probably after January when they start implementing the changes. So when you go on Medicaid, how do you get your home care services? Well, the mainstream way that Medicaid provides home care services in New York State is through something called managed long-term care. So managed long-term care is a partially capitated program. And what that means is New York State pays these plans a flat monthly premium to provide your Medicaid covered services. That premium is the same for every person who enrolls in that plan, regardless of your need for care. If I need 2 hours twice a week or 24 hours, 7 days a week, that plan is getting reimbursed the same monthly premium for every member. So the less services they give, the more of the money they get to keep, because they're getting a flat amount. It doesn't matter. So if they give less services, it's beneficial to them. And they only have to base their assessment on task-based needs: dressing, bathing, toileting, walking, transferring. And then, we get the other stuff, which is housekeeping, laundry, meal preparation. But the physical tasks are the big drivers of the care, and they won't provide any time for supervision or safety. So if you tell the evaluator, well, my mother's really unsteady on her feet, we're so worried, she's had a lot of falls, she's high risk for falling, somebody must be with her all the time, that's not going to buy you hours. They're going to say, we don't cover that. So that makes getting services for people with dementia who are physically functional much more complicated, or people who are high risk for falls and whatnot. So it's a tough plan to deal with. It's not consumer friendly whatsoever, in my opinion, in my experience, and they try to really keep the hours at bay. Sometimes people get good services and hours out of them, but often it's less than what they want. But the enrollment is quick. You can get into a plan within 2 to 4 weeks after your Medicaid's approved, and it does roll along relatively quickly. So the Nursing Home Transition and Diversion Program is a waivered service. It means it falls outside of your traditional Medicaid services. And they can provide not only the task-based care, the dressing, the bathing, the toileting, but they can provide for supervision and safety. They are the perfect program for a dementia patient who's physically intact but needs a lot of oversight. They are the perfect program for somebody who's high risk for falls and needs supervision and safety, but doesn't qualify for somebody there for the hours they need under managed care. So they're a great alternate resource. However, they take 3 to 4 months to onboard somebody once you have your Medicaid and your referral is in. So it's a longer process to get services. They also tend to work more with, believe it or not, they want to give you a split shift for 24-hour care, which is 2 12-hour shifts, rather than somebody sleeping in your house overnight, which for somebody with dementia means a lot more caregivers in the home. It seems contraindicated, which is typical of government programs. So they want to spend more money and give you more aides and make more staffing than is necessary because it's the nature of the program. However, with some finagling and the proper planning, we can get the NHTD waiver program to allow for a live-in aide. So both programs with the right planning can also allow you to use something called the Consumer Directed Personal Assistance Program. And that's a program that allows you to choose your own caregivers to work for you. There are some rules. You cannot have a spouse be paid to be your caregiver. If you have, if your adult child is your power of attorney, they cannot be paid to be your caregiver and be your power of attorney at the same time. So in an instance where you have like 2 children listed as power of attorney, one can act as your power of attorney, the other can register to be your aide, but they both can't do it. The person has to be legal to work in the United States. They do not have to be a citizen, but they do have to have their working papers to work. And they have to be willing to be on the books and register with a payroll source. The average rate of pay in Westchester County is about $15 to $18 an hour. Similar out on Long Island and in the city. You go outside of Westchester into Rockland, Putnam, and North, and it's closer to $12 to $13 an hour. So it's unfortunate. As the minimum wage rises in those other counties, so will those costs raise. So really, it's just a matter of getting the person on board, getting them registered. And there are limitations to how many hours per week people can work. But again, that gets a bit into the weeds. So, so that's pretty much the presentation. I know it was a lot of information very quickly. My goal is just to educate people and give you the general sense of what Medicaid can do. It can be a really, really great resource, but there are limitations. For instance, if you live in a hard to serve area like Katona or Somers, and there's no buses, it can be hard to get staffing for 4 hours a day. If you are, that's the biggest problem. I have a lot of difficulty staffing in areas outside of Lower Westchester, but it can be done. So that's pretty much my presentation. I don't know if you want to open it up for questions. If anybody has any, I'm happy to try and answer. And that's pretty much it.
Thank you so much, Colin. Let me get back on video here. Okay, we've got a couple people in the audience. Feel free to unmute yourself if you want to ask a question by voice. If you're not sure how to do that, you can hold down the space bar on your keyboard while you speak, and that will temporarily unmute you. We have a comment in the chat saying thank you for the presentation.
You're quite welcome. Thank you for having me.
And we'll just give a moment in case there are any other questions or comments. Okay, well, with that, I am going to go ahead and end the recording. And just